Hi, I'm Dr. Misako Nagasaka. I'm a medical thoracic oncologist over at University of California, Irvine. And let me start by sharing my screen. All right, I hope everyone can hear me all right. I was asked today to talk about novel treatment approaches in ALK and ROS1 positive non-small cell lung cancer. Here are my disclosures. And whenever I give a talk on any targeted therapies, I always start out with testing because if we can't find it, we can't treat it, right? So it's really important to ensure proper molecular testing. ALK and ROS1 are important biomarkers to check, as you can see right here. All right, so what is an ALK fusion? So when a fusion occurs in ALK, it activates downstream pathways and promotes cancer growth. ALK fusions are known to occur in 3 to 5% of non-small cell lung cancer patients, often in younger men. As shown in this diagram, multiple drugs have been approved for ALK. This is the NCCN guidelines. The NCCN guidelines list alectinib, brigatinib, or lorlatinib as a preferred Category 1 recommendation for first-line use. Category 1 means that it is based on high-level evidence, and there is uniform NCCN consensus that the intervention is appropriate. So first, I wanted to start by looking at ALEX. ALEX is a first-line study that compared alectinib against crizotinib. In the initial publication, the investigator assessed median progression-free survival was not reached, and the blinded independent review was median progression-free survival of 25.7 months. The final analysis, published in 2020, reported an investigator-assessed median progression-free survival of 34.8 months. And of note, the blinded independent radiology review of PFS was not repeated beyond the primary analysis. Now let's look at the data of CNS activity in ALEX a little bit more closely. In the intention to treat population, the 12-month cumulative incidence of brain progression was 9.4% with alectinib and 41.4% with crizotinib. In those who had brain metastasis at baseline, the cumulative incidence at 12 months was 16% with alectinib and 58.3% with crizotinib. While in those who did not have brain metastasis at baseline, the cumulative incidence at 12 months was 4.6% with alectinib and 31.5% with crizotinib. Now moving on to brigatinib, ALTA-1L was the first-line study comparing brigatinib against crizotinib. The initial publication reported the blinded independent review committee assessed 12-month progression-free survival to be 67% with brigatinib. From the final analysis published in 2021, the blinded independent review committee assessed median progression-free survival was 24 months. The last ALK-related phase 3 study that I wanted to review was CROWN, and CROWN, as shown here in the study schema, basically compared lorlatinib against crizotinib. Of note, asymptomatic, treated or untreated brain metastases were allowed. From the interim analysis of this study, the median progression-free survival of lorlatinib, as assessed by, again, the Blinded Independent Review Committee, or BIRC, still has not been reached, and this is at a follow-up of 36.7 months. The hazard ratio by Blinded Independent Review Committee for the overall intention to treat population was now at 0.27. The hazard ratio of 0.27 is something that is very, very strong. Hazard ratio of 0.27 in this setting means that lorlatinib provides a 73% risk reduction of progression when compared to crizotinib. Of note, the 24 months progression-free survival rate of lorlatinib was 68% and 36 months was at 64%. Here is data on intracranial progression, or I should say lack of. The curve showed the time to intracranial progression, and the median time to intracranial progression obviously has not been reached for lorlatinib treated patients, again with a very low hazard ratio of 0.08. Why is this important? Well, obviously, preventing brain metastasis is important, but it really is important from prevention of symptoms standpoint. So this slide shows results from a retrospective study of 213 ALK-positive non-small cell lung cancer patients with brain metastasis who were treated on crizotinib. And as you can see here, the incidence of symptoms such as fatigue, nausea, vomiting, headaches, pain or numbness, altered mental status, seizures, and others significantly increase post-brain metastasis being diagnosed, which supports the clinical importance of preventing brain metastasis in order to protect the quality of life of patients. So how does it compare? Here is a table comparing alectinib, brigatinib, and lorlatinib. While cross-trial comparisons should be done with caution, the cumulative incidence rate of brain progression as first event at 12 months is lowest at 2.8% with lorlatinib when compared to alectinib 9.4% and brigatinib 9%. Here is a little bit more deeper data on the CNS data from CROWN. In the intention to treat patients, the 12-month cumulative incidence of brain progression was 4% with lorlatinib and 34% with crizotinib. In those who had brain metastasis at baseline, the cumulative incidence at 12 months was 10% with lorlatinib, whereas it was 73% with crizotinib. And in those who did not have brain metastasis at baseline, the cumulative incidence at 12 months was 1% with lorlatinib and 19% with crizotinib. When talking about lorlatinib, I think it is really important to also review the adverse events, especially CNS-related adverse events. As shown here, CNS adverse events occurred in 39% of patients in the lorlatinib group, and most were grade 1 to 2. The most common CNS adverse events were cognitive effects, speech effects, and psychotic effects. In an analysis of 103 treatment-emergent CNS adverse events in the lorlatinib group, 59% required no intervention, 15% required dose interruption only, and 14% required concurrent medication only. Here are some tables and figures, again comparing alectinib, brigatinib, and lorlatinib in the first-line setting. Again, while cross-trial comparisons should be done with caution, lorlatinib appears to have the longest PFS, and it may matter when you get it, as lorlatinib post-second generation ALK TKIs have shown a median progression-free survival of only 5 to 6 months. Now, is there a fourth generation ALK inhibitor coming? And the answer is yes, there is. Nuvalent 655 or MVL 655 is a novel brain-penetrant ALK inhibitor, and it is designed to remain active in tumors that have developed resistance to first through third generation ALK inhibitors. It can treat solvent front G1202R mutation or compound mutations, and it inhibits ALK over the structurally related tropomyosin receptor kinase or TRK family to avoid TRK-related CNS adverse events. MVL-655 is currently being investigated in the first-in-human phase 1/2 ALCOVE-1 study. Now, switching gears a little bit to ROS1, when a gene rearrangement occurs in ROS1, it can drive tumor cell proliferation, survival, and metastasis. ROS1 rearrangement is known to occur in about 1% of non-small cell lung cancer patients. Importantly, at the time of diagnosis, 20 to 30% of these patients present with accompanying brain metastasis. Of the 1.5 million new cases of non-small cell lung cancer worldwide each year, approximately 15,000 may be driven by the oncogenic ROS1 fusion. What is available for ROS1? Well, the two approved ROS1 tyrosine kinase inhibitors are crizotinib and entrectinib. There are a few off-label agents that are available, and there are 3 second-generation ROS1 TKIs in development, which we will talk about in the following slides. So first thing to note, ROS1 structure is very similar to ALK. Indeed, ALK and ROS1 share 77% of amino acid identity within the ATP binding sites. Due to this high degree of homology between the ALK and ROS1 tyrosine kinase domain, the ROS1 tyrosine kinase have been known to be highly sensitive to crizotinib in preclinical models and from case reports. The FDA approval of crizotinib in patients with ROS1 non-small cell lung cancer was based on the expansion cohort of 50 patients utilizing crizotinib with ROS1. As you can see here, the objective response rate was 72%. Median duration of response was 17.6 months. Median progression-free survival was 19.2 months. Common adverse events included things like visual impairment, diarrhea, nausea, edema, constipation, and vomiting. Entrectinib is also FDA approved. Entrectinib demonstrated an objective response rate of 77%, duration of response of 24.6 months, and median progression-free survival of 19 months in the overall population. And in the patient population of baseline brain metastasis, the response rate was 74%, the duration of response was 12.6 months, and median progression-free survival was 13.6 months. For the most part, entrectinib was well tolerated, as most of the treatment-related adverse events were low grade. But because entrectinib is also a potent TRK inhibitor, the occurrence of adverse events potentially related to TRK inhibition, such as dizziness, weight gain, paresthesias, and cognitive changes, was not unexpected. There is some data on ceritinib and ROS1, but from a limited number of patients. For crizotinib-naive patients, the response rate was 67%, duration of response was 21 months, and median progression-free survival was 19.3 months. There is also data to support the use of lorlatinib in ROS1. The lorlatinib study enrolled more ROS1 patients compared to the ceritinib study, totaling out 69, and 21 were tyrosine kinase inhibitor naive, and 40 had crizotinib as their only prior tyrosine kinase inhibitor. The response rate was 62%, and median progression-free survival was 21 months in the tyrosine kinase inhibitor naive group, and in the prior crizotinib-only group, the response rate was at 35%, median progression-free survival was 8.5 months, and median duration of response was 13.8 months. The intracranial objective response rate was at 50%. Here is a quick summary slide of the approved and unapproved ROS1 tyrosine kinase inhibitors. Now moving on, here is a slide on the mechanism of resistance to crizotinib or entrectinib in ROS1 non-small cell lung cancer patients, and the slide credit goes to Dr. Jessica Lin. As you can see from the pie chart, G2032R was seen in 33% of those with resistance to crizotinib, and the current available ROS1 inhibitors are not potent against ROS1 G2032R, and as shown in the IC50 table, this is where the next generation drugs like repotrectinib and taletrectinib come in. Repotrectinib is a next-generation ROS1 TRK inhibitor designed to overcome tyrosine kinase resistance, especially solvent-front G2032R, which first-generation tyrosine kinase inhibitors cannot overcome. Repotrectinib is highly potent and structurally differentiated with a small or low molecular weight and rigid 3D macrocycle, and it is designed to bind completely inside the ATP pocket, even in the presence of resistant mutations. It has the potential to address resistance from prior lines of tyrosine kinase inhibitor therapy, but it may also prevent or delay the emergence of these resistant mutations. As shown here, the objective response rate after one prior ROS1 tyrosine kinase inhibitor and no prior chemotherapy was 37.5%, with the clinical benefit rate being 82.1%. Dizziness and dysgeusia were common. Here is data on G2032R and brain efficacy. In those patients with G2032R resistance mutations, the objective response rate was 58.8%, with 70% of patients exceeding 6 months of duration of response. The intracranial efficacy was also promising too, with intracranial objective response rate at 87.5% in ROS1 tyrosine kinase inhibitor naive and 41.5% in one prior ROS1 tyrosine kinase inhibitor and no chemo. Taletrectinib is another second-generation ROS1 tyrosine kinase inhibitor. Here's data from the Chinese phase 2 study, or the TRUST study, which showed an objective response rate of 50% in crizotinib pre-treated patients. The intracranial objective response was excellent at 91.7%. There is also an ongoing study called TRUST-2, which is the global version phase 2 study of taletrectinib. The last agent that I wanted to introduce today was MVL-520 or Nuvalent 520. This is a very important new ROS1 inhibitor that is coming out. It is considered brain penetrant and a TRK-B sparing small molecule inhibitor of ROS1 with activity against a frequent drug-resistant mutation of G2032R, as well as others, including D2033N. The initial preliminary efficacy results were presented last year and showed an objective response rate of 48% in all evaluable patients, 78% in those with G2032R, and 73% in those with history of brain metastasis, and 53% in those who had 2 or more ROS1 tyrosine kinase inhibitor and 1 or more chemotherapy treatment, and 50% in those with prior lorlatinib or repotrectinib treatments. But we must be careful, as the numbers that have been reported here are relatively small. Again, although the numbers are still limited, MVL-520 appeared to also have promising CNS data and safety data in the patients with measurable CNS metastasis. There was 3 out of 3 patients with intracranial response, and the objective response rate was 73% in response evaluable patients with history of brain metastasis. Importantly, no brain progression was observed in any of the 35 treated patients. Safety was also looking promising too, with no DLTs or dose-limiting toxicities, no treatment-related serious adverse events, no adverse events leading to dose reduction or discontinuation, and no treatment-related dizziness. All right, here is the list summarizing the 3 second-generation ROS1 tyrosine kinase inhibitors in development. They all appear promising with brain activity as well as activity against the resistant G2032R, and we will await for these studies to mature. Thank you for your attention.
Thanks, Dr. Nagasaka. My name is Stephen Liu. I'm a medical oncologist, the director of thoracic oncology at Georgetown University, and I will have the pleasure of discussing RET fusions and some other less common targets. I'll try to build off of what Dr. Nagasaka has shared with us so far, and should be able to see my slides now. If not, you can use your imagination. These are my disclosures. We're talking about RET fusions here, and fusions, as we know, are the same as chromosomal rearrangements. These are genomic alterations. These are findings in a subset of non-small cell lung cancer tumors. It is rare to find some of these, but they're very important. When we talk about these types of genetic changes, these are acquired. And by that, we mean they're not present at birth. They're not things that we pass on to our offspring. It's unclear really why these occur. And we're still in the process of understanding why these fusions develop in some people, but not others. Identifying these fusions when they're present, though, is critical to care. It tells us a little bit about the cancer. It explains the biology, but it's much more than an academic exercise. What these fusions tell us is really how to attack the cancer. It exposes these unique vulnerabilities to these cancer cells, and it guides our treatment right from the beginning. It guides us towards targeted therapy. It steers us away from ineffective immunotherapy. But individual tests for these fusions is impractical, is very difficult. In the early days of targeted therapy, we would do tests like FISH for ALK and for ROS1, but our list of relevant drivers increases and stretches past a dozen. We can't do all of those tests. It's inefficient. It uses up a lot of tissue. It's actually more expensive. Really, in the modern days, next generation sequencing is our best approach. But the type of sequencing is also relevant. And I want to make a quick plug for the potential added value of RNA sequencing. When we talk about next generation sequencing in the US, that's primarily using DNA as the nucleic acid. And this is a good test. It's very good at detecting certain things, such as EGFR, very easy to find on DNA-based next generation sequencing. But RNA sequencing adds a dimension which in some cases is useful. Not for everyone, and certainly it does add cost, it does add time and expertise, but there can be value in finding these alterations. This is a study that was released from Dr. Raima Benayyed when she was at Memorial Sloan Kettering. And they took patients with advanced non-small cell lung cancer. All of them got DNA-based next-gen sequencing. And if they found a driver, they moved over. But those that did not have a driver using DNA NGS, there were 254 of those. They sent those for RNA sequencing. And out of those 254, they found an actionable driver 13% of the time. 13% is not a small number. And what did they find? They found things like ROS1. That was the most common one that they found. ALK, NRG1, NTRK, RET, the things we'll talk about now. If we would have missed these alterations, these patients would have gotten the wrong treatment, because there really is a right and wrong treatment in many of these cases. If we miss those drivers, patients are treating the wrong way. And so the stakes are really high. If we don't find anything by DNA-based NGS, we need to start thinking of RNA sequencing as a way to really properly and thoroughly test for these alterations. So let's talk about RET. RET stands for rearrangement during transfection, RET. This is a receptor tyrosine kinase protein, and it has a normal function. So this protein plays a role in our development. It's important for cell growth. It's supposed to do that, but generally when we're in development, not as adults. When there's too much RET signaling or inappropriate RET signaling, when RET is turned on, when it's not supposed to be turned on, that causes uncontrolled growth. That leads to cancer. And because of that feature, RET, the gene RET, is referred to as a proto-oncogene. Now, RET mutations are associated with cancer syndromes. RET mutations are things that we inherit and can pass on. They're associated more with thyroid cancers and syndromes called multiple endocrine neoplasia. Now, that's not what we're talking about for lung cancer. For lung cancer, we're talking about RET fusions, RET rearrangements. These were first described in the laboratory in 1985, first seen in a patient's tumor in 1990, but the first RET fusion in lung cancer was described in 2012. So we have about 10 years, which is relatively short history, but we've come a long way. When we first started to see RET fusions were present in lung cancer, we knew that there were drugs out there that were active against RET. RET's not common. These fusions are present in about 1 to 2% of lung cancer. There are different fusion partners. When we talk about a fusion, we're talking about two genes coming together. The RET is providing the kinase portion. The other gene, the fusion partner, is most frequently KIF5B, though we also see CCDC6, NCOA4. These letters probably don't carry much meaning today. With some of the older drugs, they actually did have some input into how well those medicines worked. With the current drugs, they don't seem to matter too much. They may be important in the future. For now, all that's relevant is that RET fusion portion. And we have a lot of drugs off the shelf that are available, that are approved for other cancers, such as kidney cancer, thyroid cancer. These medicines do block RET signaling, but they do a lot of other stuff as well. They're multi-kinase inhibitors. They're what we called dirty kinases in the past, where they will block RET, but you're also getting a blockage of a lot of other things too. Now, blocking those other proteins might be important for kidney cancer, for thyroid cancer, not so much for RET cancer, but they all come together. It's part and parcel. So when we looked at these older multi-kinase inhibitors, they worked. The response rate probably around 20%, but they had a lot of side effects. And those side effects were the result of blocking other proteins. RET inhibitors were listed in the NCCN guidelines, these multi-kinase inhibitors, as options to consider, but they weren't frequently used, again, because of toxicity. What we really wanted was a selective RET inhibitor, something that could block RET signaling, but not block a lot of other things. If we could design a selective RET inhibitor, there's not much consequence for shutting off RET signaling when we're an adult. So we can live without RET as an adult. If we completely block RET and don't block anything else, we should have a drug that works very well, that works for a long time, and that doesn't have as many side effects. And so we relied on our chemists, our medicinal chemists, to design these drugs, and that's what they did. There are two FDA-approved selective RET inhibitors, selpercatinib, previously LOXO-292, and pralsetinib, previously BLU-667. These are both approved in 2020. They are oral agents. They work well through the body and through the brain, and they're both very well tolerated. Both agents represent current standards of care for the treatment of RET fusion-positive non-small cell lung cancer. So let's look at them a little more closely. Selpercatinib was studied in the Libretto 001 study. This is a phase 1-2 study. They looked at 356 patients over the course of 3 years. They established a dose, 160 milligrams twice daily. Looking at people who had already had chemotherapy, we see the response rate 61%. After initial chemotherapy, the standard at the time was chemotherapy number 2, second-line chemotherapy, something like docetaxel. The response rate to docetaxel is about 26%. Here, the response rate 61%, including 7% with a complete response. Again, for terminology, in a trial, when we say response, we mean the tumor has shrunk by volume by about 30%. So we're talking about a significant reduction in size of the tumor. These responses were quick, happening in a median of about 2 months. So generally, the first CT scan, we can already see it working. The responses were durable, with a median duration of response of just over 2 years. And the longest response was ongoing at 3.5 years when this paper was published. Median progression-free survival about 2 years. This is a waterfall plot. We use this a lot to visually show how well this drug works. In a waterfall plot like this, each of these vertical bars represents one patient's tumor. We start at 0, and if the bar is pointing down, that means the best response was a reduction in size. And the further down it goes, the smaller it got. And those at the far right of the slide, where it got down to minus 100, those are the complete responses. If a tumor got bigger and never got smaller, we'll see that on the left as a bar pointed upward. When you step back and look at this waterfall plot, you can see the vast majority of patients had some reduction in size of their tumor. Now, when the drug was given as the very first treatment with no other prior therapy, the outcomes were even better. The response rate, 84%, including 6% with a complete response. Responses, again, were quick, were durable, and some were ongoing at the time the data were published. There's no limit as to how long any of these drugs can work, and for some people, the medicines do continue to work extraordinarily long periods of time. Here you see the waterfall plot. Here, every patient with some reduction. Importantly, we know that for RET fusion lung cancer, these are tumors that, for some reason, are more likely to spread to the brain. And so when we're designing the optimal drug, we want a medicine that's going to affect the brain cancers. And so what we see here is an intracranial response rate of 85%. The medicine works well in the brain, including 27% with a complete response. In patients who did not have spread to the brain when they started, they were unlikely to develop brain metastases while taking this medicine. All right, we refer to this as a neuroprotective effect, that this medicine can prevent brain metastases from developing. And in 178 patients, the risk of developing brain metastases at 2 years was less than 1%. Selpercatinib, a very effective drug, an approved drug, and a good initial option. And certainly, this is something I would prescribe as first therapy, not as something after chemotherapy. This is not the only drug approved. As we mentioned, pralsetinib, or BLU-667, is also an approved drug, and a lot of similarities here. Another selective RET inhibitor, enrolled around the same time period over those 3 years. This is once daily instead of twice daily. And when we look at efficacy, pretty similar. The response rate here, about 60%. Again, responses are quick, with a median time to response of less than 2 months. Durable responses here on average about 2 years. And we see some tumor shrinkage in 97% of patients. Here we see the waterfall plot, nearly all tumors pointed down. Now this is color-coded by the RET fusion partner. And you can see that whether it's KIP5B, CCDC6, or other partners, they all seem to respond well. And so it's nice when we don't need to think about those details, at least for the time being. Pralsetinib, a very effective drug across the board. In the frontline setting, as we saw with selpercatinib, the drug is even more impressive, where the response rate is over 70%, where the responses are ongoing for most patients. We don't have a median yet because it hasn't stopped working for most people. And we saw some tumor shrinkage in 100% of patients. So very impressive results here with pralsetinib, and also a drug that works well in the brain. The intracranial response rate, 70%. And again, just as we saw with selpercatinib, 233 patients with no baseline brain metastases, only 2 patients, less than 1%, developed brain metastases. Shown here on the right is an image from a presentation in 2019 showing a right parietal tumor that is nearly disappearing just after 2 months of treatment. I showed this one in particular because this is my patient. And in 2023, as of right this moment, she is still doing extremely well thanks to these selective RET inhibitors. These drugs are well tolerated. They're safe. Fewer than 10% stop treatment for toxicity. The number is about 2% for selpercatinib. Again, what's important here is that the on-target effect of RET inhibition is not really relevant biologically. When we block RET, there's not much consequence to doing that. The toxicity of these drugs is mostly related to the inadvertent or spillover blockage of other proteins. Here's a table showing the side effects of selpercatinib. Now, if we look to the right, those that are related to treatment, we see about 30% have edema, but mostly mild, low-grade edema. We can see diarrhea, 27% with fatigue, and 38% with dry mouth. Some of these are paper toxicities, things that don't cause symptoms but are important to monitor, like AST and ALT elevation. Those are liver blood tests. We don't want that to get too high. Some are things that we can only find if we really go looking. At the bottom, you see EKG, QT prolongation, not something that patients will typically feel, but something we can monitor and watch out for. These are generally low-grade side effects, and they're not related to blocking RET. RET lies very close to some other kinases, and so when you block RET, you're very likely to block things that are closely related to RET, such as VEGF, which is responsible for some side effects, like hypertension, which is seen in about 28% with selpercatinib. Now, when we look at pralsetinib, there's a little difference, though. Pralsetinib has more hematologic toxicity, meaning it lowers the blood counts much more. We see neutropenia in 47% with previously treated, 43% treatment naive, so overall about 46%, but mostly low grade We can see higher grade rates of lower neutrophils, lower white counts, lower red cell counts. These generally respond to dose reductions. And so in the early stage of starting either medicine, we have to watch with blood tests and make adjustments if we see these blood counts coming down. But the lower blood counts is something that is much more pronounced with pralsetinib than it is with selpercatinib. At the same time, we don't see as much edema. We don't see as much dry mouth. And so the side effects are a little different between the two. So there are some in common. All right, hypertension or high blood pressure is seen in about a quarter of patients with both drugs. So we're starting a new RET inhibitor. We want to watch blood pressure periodically because that can go up as a result of this medicine. Liver enzyme elevation, about a third of patients in both drugs. So we need to watch with blood tests after starting and periodically. Lower blood counts, a little more common with pralsetinib. Dry mouth and edema, more common with selpercatinib. And so when we start these medicines, important to counsel patients on what to watch for and important to follow patients closely. At the beginning, we don't want to start a medicine and say, come back in 6 months. In a few weeks, we want to do some blood tests, check blood pressure, make sure patients aren't having side effects. If we see those types of side effects, we need to lower the doses. There are some unique toxicities. Hypersensitivity reaction has been described with selpercatinib. This is an uncommon event that usually occurs pretty quickly. It's a rash, a diffuse rash, head to toe, fever, joint pains all over, hands, elbows, arms, hips. You can see low platelets. You can see rising liver enzymes. You can see, in severe cases, a drop in blood pressure, heart rate, kidney injury. It can be scary symptoms with this hypersensitivity reaction. Now, this generally occurs if someone has started with immunotherapy. We touched about this a little bit in some of the earlier sessions, but when we give a targeted drug after immunotherapy, it changes the side effect profile entirely. And these drugs are much more toxic after immunotherapy than if they were given first, which is why we want to use these drugs up front and why we need to test for these drugs before giving immunotherapy. If we see this, we have to stop treatment, give steroids, and then you generally start really low and titrate up as tolerated. Then you can salvage treatment, you can re-escalate, but it is a little challenging. And shown here is a picture of the rash for one of the patients. There's also the development of chylous effusions, and these can be pleural effusions or they can be ascites, which is fluid in the abdomen. It's seen in about 7% of patients getting selpercatinib. We don't know why this happens. It doesn't seem to be related to the cancer at all, and for some reason we do not see it with pralsetinib. You can see it with other oral drugs as well, and most of them occur kind of late after being on treatment for a while. I think the important thing to recognize is that sometimes a doctor might think the cancer is getting worse when really it's this unusual side effect. And so if suddenly on a CT scan we see an effusion start to grow, you might say, well, it looks like the cancer is no longer responding to treatment. In those settings, it's important to verify that by draining some of that fluid. And if it looks like this, that's not necessarily related to the tumor at all. That might be an unexplained side effect of the drug. This is an important one too. There can be a false renal insufficiency. When we look at our kidney function, our renal function, we make a guess based on a blood value called the creatinine. Now, that creatinine is usually a pretty good marker of how well the kidneys are working, but there are some medicines that will make your creatinine rise, even though your kidneys are working perfectly. There are other ways to measure kidney function, like a blood test called cystatin C, that show us the true kidney function, but selpercatinib and pralsetinib, both of our selective RET inhibitors, fall in this category, where you take these medicines and over time you can see a rise in creatinine, but that doesn't mean the kidneys are working less well. And that's important to realize because sometimes people will have their doses of medicines dropped when really it's not a side effect of the pill and it's not a dangerous thing at all. You see that with selpercatinib and pralsetinib, but you see it with a lot of the drugs we use here and a lot that Dr. Nagasaka mentioned: crizotinib, lorlatinib, brigatinib, the MET inhibitors like capmatinib and tepotinib, entrectinib, as well as first-generation inhibitors like erlotinib and gefitinib. And so something to keep in mind when you see that rise in kidney function, it might not mean what we think. As with most of our oral agents, they don't work forever for most people, and we do still develop resistance. Resistance can be in multiple forms. It can be on-target resistance, which would be in the form of new RET mutations. The cancer alters the target so that the medicine no longer binds as tightly. The medicine is no longer effective. Those are on-target resistance mechanisms. Or there can be off-target resistance mechanisms where the RET is still being blocked, but it's now using a different pathway to survive, such as MET or KRAS. In those settings, possibly combinations or switching to a different strategy might work. If it's on target, perhaps a new generation RET inhibitor. And we do have new generation RET inhibitors. I think it's a little too early to go into most of these. They're all still license plate names with letters and numbers, but we do see some promising activity after prior drugs. We're working on these now. These are open at various centers, including Dr. Nagasaka's and mine, and we'll work on developing the next generation of drugs for those who need it. But importantly, immunotherapy is really not so effective for RET fusion lung cancers. The ImmunoTarget Registry, which was led by Dr. Julien Mazieres in France in Toulouse, looked at PD-1 and PD-L1 monotherapy. And what they saw was that for RET fusion positive lung cancer, the chance of response was only 6%, and 75% of patients had an immediate progression with no periods of stability. And so if targeted therapy is no longer the option and the trials aren't available, chemotherapy is much strongly preferred over immunotherapy. RET can also be responsible for resistance. And we can see, for example, in an EGFR lung cancer that's being treated with osimertinib, a new RET fusion can emerge, which allows that tumor to survive. And so off target for others, such as EGFR, and you can see pralsetinib being used, or selpercatinib being used. On the left, a case from Dr. Zosha Piotrowska. On the right was one of our patients at Georgetown. We're also trying to use these drugs in the early stage setting because they're well tolerated, because they work well in the brain. We think maybe they'll work as osimertinib works in the early stage setting. And so they are looking at adjuvant RET inhibitors after surgery. That's the Libretto trial. And this is ongoing now. It'll be a while before we get results. But RET fusions, rare but important events to identify. Selective RET inhibitors, very effective. Now, there are two other fusions we'll talk about very quickly. NTRK fusions, which are pretty rare, seen in less than 1% of tumors. Again, this is also one that is better detected with RNA testing. We have two drugs approved, larotrectinib in 2018, entrectinib in 2019. And if that sounds familiar, Dr. Nagasaka presented this for ROS1. Both of them are oral drugs, work very well. Larotrectinib, a response rate of 79%, entrectinib 61%. Again, the responses are quick. For entrectinib, less than a month. The median time to response, they're durable. And when we see these waterfall plots, they really work across different tumors, not just for lung cancer. Here, larotrectinib, here, entrectinib. Very effective, potent medicines, and they work well in the brain. These data are for entrectinib. But these drugs do have important side effects. So we can see, as with most of these drugs, rise in liver tests, fatigue, nausea. We can see both with larotrectinib and with entrectinib. But when we think of side effects for these agents, the big difference between this and something like a RET inhibitor is that these are on-target effects, which means if you have a really well-designed specific NTRK inhibitor, you're still going to have these side effects because these are the result of blocking NTRK. While the tumor is using NTRK to survive, NTRK still plays a role in our normal function. So when we block that, there's a price to that. For example, we block TrkA. TrkA is responsible for sensation. And when we block that, and TrkC also for sensation, proprioception, the sensation of where we are in space. And so when we raise our foot, we know that it's raised because the sense of proprioception. If we block TrkA, the tumor responds, the tumor can't survive, but our sensation is altered as a result of that. And we have trouble with proprioception, which alters the way we walk, which manifests as things like dizziness or unsteady walking. TrkB is responsible for appetite. And so when we block that, our appetite starts to go way up. And so we see weight gain, but it's not water weight or retaining fluid. It's from hyperphagia, from eating. And so when we see weight gain, again, this is something that occurs more and more over time. And it's not a small amount of weight gain. Some patients can gain, 10, 20, 50. We saw one almost 100 pounds weight gain. So there can be a quite significant amount of weight gain, and it's the result of blocking NTRK. And there are medicines we can use now, shown on the right, like GLP analogs, topiramate, sibutramine, medicines that our rheumatologists and endocrine physicians are really using for other purposes that can be effective here. But this also responds to dose reduction. Dizziness, seen with a lot of NTRK inhibitors. And when you think of lightheadedness, vertigo, dizziness, imbalance, they're probably all describing the same thing. And this is the result of NTRK inhibition. And when we see this, it means we're given too high of a dose, and you have to lower the dose, and that way patients can stay on treatment. Now, withdrawal pain is a very interesting one. This is one in the phase 1 study, in the early studies of this drug. When we first saw this, we didn't know what was happening. But this is basically because NTRK plays a role in our sensation of pain. So when we block NTRK inhibition, the body increases the amount of pain receptors. And overall, it just evens out. But then when you stop an NTRK inhibitor, you can have these diffuse body aches as a result of this withdrawal. And then if you take a dose of the NTRK inhibitor again, pain immediately goes away, like within a couple hours. It's a very interesting physiology. And so if a medicine is no longer being used and we're stopping it, we usually kind of taper it down a little, and you got to make sure you have a supply of pain medicines to get through it. It will pass. It's not a permanent effect, but it's a very unique side effect. So when we stop these NTRK inhibitors or any drug that blocks NTRK, you can sometimes see this withdrawal pain syndrome, which can be very serious. There are new drugs. We heard about repotrectinib from Dr. Nagasaka. This is also being used for NTRK tumors and looks very active after prior inhibitors, though not yet FDA approved. It does have fast track designation, but these side effects for NTRK are the important thing to watch for. And NRG1, these are very rare tumors. These are generally only found with RNA sequencing. These are seen across multiple cancer types. Here's some data we presented at ASCO about what tumors we find them in. It's a big tumor, a big gene rather, and so you do need to use RNA sequencing to find it. It's a complex physiology, but basically NRG is a ligand that binds to HER3. HER3 then binds to HER2, and then we lead to signals that propagate growth in cancer. And when we have an NRG1 fusion, it keeps that NRG1 really close to the HER3. So it's constantly signaling for growth. And that's why these NRG1 fusions can lead to cancer. And how do we block that? Well, we can block it primarily by interfering with the HER2 pathway. This is a registry that we led. Dr. Nagasaka was a part of this, looking at NRG1 fusions in lung cancer. What we learned is that these tumors do not respond well to treatment. If we look at a combination of chemotherapy and immunotherapy, for example, the response rate was 0. And so the standard treatments do not work well for these cancers. There are no approved drugs yet for NRG1. Afatinib is a drug we use for EGFR that blocks HER2 signals that has shown responses, some shown here, generally cases. And so it's hard to know exactly how well it works. Seribantumab is a HER3 antibody that did show response rates of about 33%, but this drug has been discontinued and is no longer being investigated. The only one left in trials is zenocutuzumab, and that's a bispecific antibody in the NRG1 study that binds to HER2 and HER3 to block signaling. And we've seen in early results a response rate about 34% overall and in lung cancer, with relatively few side effects. A very well-tolerated drug, but not approved. Currently FDA fast track designation. So to summarize here, when a fusion's there, we've got to find it to choose the right treatment. RET and NTRK are both actionable with approved drugs. NTRK has some unique side effects to be aware of during and after treatment. NRG1, if we see one of these fusions, we got to get to a trial in a hurry because the standard treatments do not work very well. And for all of these, we expect trials to really be the future for how to manage these unique rare events. And so with that, I'll stop, and I think we move on to the Q&A portion.
Dr. Nagasaka, if we could have you turn on your microphone and camera, and we will get to the Q&A.
I think it's coming. No?
We can hear you, but we can't see you.
But I can start with the first question. And while we're waiting for your camera to come on, Dr. Nagasaka, there's a question here from the audience, and maybe I can ask to you. Is RNA testing available commercially, and where can we do RNA testing? Dr. Nagasaka, is that something you're doing in your practice?
Sure. So we send out molecular testing to testing companies, and Stephen also knows his company. I use Caris Life Sciences, and the platform does include RNA sequencing. I find it very useful. The only downside is sometimes it takes a longer time to get all of the results back. I'm still working on my camera.
Yes, right now it's not something that can be done easily through blood. And so the blood-based tests that are available now commercially do not detect RNA changes. They're not RNA-based. There are some in development early on that we think might be able to, but they're not quite ready yet. So most of the blood-based liquid biopsies, those are DNA-based. And most NGS in the US is DNA-based. There are commercial tests, commercial assays that do it RNA. Sometimes you have to request it. I think the key is really knowing what's been tested, and it's all these details that really matter. So, Dr. Nagasaki, I asked another question while working on your camera. Can we get unapproved treatment options for ROS1 like ceritinib, or should they only use approved drugs? And will insurance cover these off-label uses for ROS1 inhibitors?
So I haven't used ceritinib. I quite honestly don't see the advantage of using ceritinib when there are other agents that are available and effective. But I could see perhaps a situation where you may want to consider the use of off-label drugs, but not ceritinib in this case.
And not as your first treatment, correct?
No.
Yeah.
So, as mentioned in my talk, alectinib, ergatinib, and loratinib are all Category 1 NCCN recommended first-line ALK inhibitors. So, those are where I would start with. But I guess there could be certain scenarios when tolerability is an issue that you might want to switch to something else.
I think this question was about ceritinib for ROS1. And
Ah,
for ROS1,
so and crizotinib and entrectinib are the only approved.
yeah, I agree with that. I think that off-label use of ceritinib and lorlatinib is usually after progression on crizotinib and entrectinib. And I think that there's been some activity with lorlatinib in that setting. It is off-label use, but the preference really is to try to get access to one of these trials where I think the outcomes are quite a bit better. But here's a very specific question, Dr. Nagasaki. How effective is cabozantinib for ROS1 after progression on crizotinib?
So I think that is an excellent question. And unfortunately, there isn't like a big data set for cabozantinib use, but there are several preclinical studies and case reports that showed that cabozantinib appears to have activity in specific mutations after crizotinib resistance. And these include things like D2033N and L2086F. So I think in those scenarios where you have a specific resistant mutation after using crizotinib, that cabozantinib might be able to cover for, that is an indication where I would probably try to get an off-label use of this drug.
Yeah, I agree. Cabozantinib actually has a lot of activity, even for some of the compound mutations we can see with crizotinib and entrectinib. And so on plastic in the laboratory, it's actually pretty effective at overcoming resistance. But this is in the setting of certain resistance mutations when we have on-target resistance. Now, if there's off-target resistance, cabozantinib may be a little less likely to provide that same benefit. So if possible, if a tumor were to progress on crizotinib, I think that doing a biopsy and repeating the testing could provide some useful information. And if you really saw something else, you probably wouldn't see MET amplification after crizotinib. But if you saw KRAS amplification, for example, then cabozantinib probably not going to be a very good choice, and chemotherapy may be more appropriate. Is that a reasonable approach, Dr. Nagasaki?
Yeah, I agree.
Of course, if trying cabozantinib, we also have to remember there are a lot of side effects with that drug. That is a very difficult drug. Do you have a lot of experience with that, Dr. Nagasaki?
Yeah, I find the skin toxicities to be pretty tough, as well as GI toxicities.
Yeah, it's difficult medicine. A lot of hand-foot syndrome,
Correct.
sometimes in the mouth, diarrhea. So it is a challenging medicine, and I think you can make a good case for using chemotherapy in that setting. A lot of ROS1 dependent cancers respond very well to a chemotherapy drug like pemetrexed, right?
That is correct.
All right, Dr. Nagasaki, we're still waiting for your camera, but I can
Sorry,
throw this
I'm
question.
sort of giving up on this.
Okay.
Yes.
There's a question about ALK.
Mhm.
So an NGS report showed a very rare DCTN1 ALK fusion. We have high tumor burden, brain and bone metastases. Is alectinib still effective in this case to avoid brain and bone radiation?
So, I personally have not seen this DCTN1 ALK fusion. Stephen, have you?
No, I've not. And I think that this is a setting where, if at all possible, I try to talk to the testing company and see if, we have a preserved kinase domain.
Right. Is it in frame and that kind of thing?
If it is an in-frame fusion, we expect it to be significant. One of the sort of nice things about ALK fusion lung cancers is that when they respond pretty quickly. And so if we were to start a drug like alectinib, you would know, I think, relatively quickly whether it was working.
Agreed.
And so it might be a case where you start a drug like alectinib while you're planning radiation, and then on a scan you do in a few weeks, if you already see a response, then you can pivot and continue to ride that response. Is that something you might consider?
Yeah, I think that would be very reasonable.
Now, here's a slight twist in that question that's also from the chat here. There's a patient with brain metastases who was receiving alectinib, but then many new lesions appeared after 1 year of therapy. And so what's the best option here? To switch to lorlatinib immediately, or to do stereotactic radiosurgery, some sort of radiation, and then switch to lorlatinib? What are your thoughts?
So I think there could be different considerations to be given, and I don't think there's like one correct answer. I tend to prefer lorlatinib use in this setting, and I tend to try not to radiate too much, whether it be SRS or, and I really try to avoid whole brain radiation therapy, especially in patients with ALK and ROS1. Their survival is much better compared to people who don't have these alterations. And I have seen terrible cases of radiation necrosis because their survival could be 5, 6, 7, 8, 9, 10 years. And you could see late long-term effects of radiation in those cases. So that is why I try to avoid the use of radiation, whether it be SRS or gamma knife or whole brain radiation. But I think you can also argue that it really depends on each scenario. Like if there was an area that's very important in the brain that needed quick treatment, or if there were signs of blood products, was it bleeding? Sometimes radiation can work very quickly and is effective. So I would have a very detailed discussion with the treating oncologist as well as radiation oncologist and go through all the options.
Yeah, that's the key. It's not something that's so formulaic. That when we
Right.
talk about brain metastases, the details matter a lot: size, number, and location. And so, certainly, depending on where they are, we might tolerate a little more growth in the frontal lobe than we would in the midbrain or brain, for example. So, that's a very good point. I agree that here the word was many new brain lesions, and I think that this is a setting where if you do radiation, you might be radiating a lot, and radiation necrosis can cause a lot of trouble down the line, a lot of confusion, a lot of symptoms, a lot of morbidity. So I think that a case like this, moving to a new CNS penetrant or more effective ALK inhibitor, makes sense, whether it's lorlatinib or perhaps as part of a clinical trial. Dr. Nagasaka, there was a question about ROS1. Are there any pitfalls with ROS1 adenosquamous lung cancer? So we know that these are generally adeno, but you can see it in squamous histology and adenosquamous. Can TKIs, can pemetrexed still be effective for this squamous part of the tumor? And is bevacizumab safe in the case of a mixed histology? So a couple of very good questions. Why don't I let you take a step?
So those are excellent questions. I also think that there might not be a straightforward answer to this one. It is true when you have a squamous histology, the efficacy of pemetrexed isn't that well, and sometimes I like to use a more general chemo like taxanes. But in this particular scenario, ROS1 was also detected too, right? So in a scenario like that, I would probably start with a ROS1 inhibitor and see how much response you get. And then, if at all possible, would try to biopsy the residual disease or resistant disease and see what's going on. And you might see that the only area left is actually squamous now.
Yeah, I agree. I think that the TKIs can work even in a pure squamous histology. We can see responses. There's some thought that maybe the outcomes are not quite as robust, but small numbers to really be sure. So I think the TKI certainly is appropriate. Pemetrexed is only approved for non-squamous, and it's not a question of safety, it's a question of efficacy. Squamous tumors have a high expression of something called thymidylate synthase, which predicts response to or resistance to pemetrexed. And so, as Dr. Nagasaka said, we usually favor other chemotherapy agents like taxanes. Bevacizumab is a tricky one, and while it sort of depends on the details and how much squamous histology is there, the concern of bevacizumab in a squamous histology is an increased risk of hemoptysis, which is bleeding with coughing and in some cases can be fatal. And that's probably a bit risky. So bevacizumab, something we probably avoid if there's a lot of squamous component, but the TKI certainly I would move forward with. Here's a question, sort of forward-facing question for you, Dr. Nagasaka. What are your thoughts on TKI neoadjuvant studies? Do you expect complete pathologic response? Do you ever consider to use off-label targeted therapies preoperatively to make a tumor operable? And so let's think of that for ALK as an example for that.
Sure. So I think that is an excellent question. And I actually think that that is where the field is moving forward. There are clinical trials investigating the use of neoadjuvant tyrosine kinase inhibitors in different settings, including ALK. So I think the board answer, the correct answer would be to investigate those in a clinical trial setting at this time. However, I will admit that I have a few patients that I've had extremely incredible responses to tyrosine kinase inhibitors to the point that, I considered local therapy, and sometimes that means radiation, sometimes that means lobectomy. And interestingly enough, I had a lady who had an excellent response, and her primary tumor basically halved. So I asked the surgeon to take her to lobectomy, and it was path CR. So I actually have seen a path CR with ALK TKIs.
I think that today, if someone had a resectable tumor, 3-centimeter upper lobe tumor with a hilar lymph node, and I knew there was an ALK fusion, I'd probably just go right to surgery. I don't know that there's a long-term benefit from the use of targeted agents. The question was supposing, could you convert someone that was not resectable to resectable? And I think that's pretty controversial right now. You expect high response rates, but we don't expect the targeted agents to be curative all on their own. So overall, if something's resectable today, I don't know that there's a lot of value for neoadjuvant targeted therapy versus just resection and then consideration of off-label adjuvant. But what's your opinion on that, Dr. Nagasaka?
Yes, I have that situation as well. Oh, and the case that I described was initially completely unresectable. Anyway, yes, there is also the study for adjuvant alectinib that is supposed to be coming out soon, right? That basically is a very interesting one. So basically, these patients were randomized to post-op chemotherapy versus alectinib. And I think we are about to hear those results. And hopefully, it is a positive one. And right now, I don't have the courage to omit adjuvant chemotherapy just yet. So in such cases where I've had patients post-surgery come to me and I see an ALK and not an EGFR, if they qualify for adjuvant chemotherapy, I actually give them adjuvant chemotherapy because that is the current available standard. And then I have off-label use, put alectinib on patients on alectinib. I will see what happens to the studies.
And can you clarify the question here? What is a path CR? What do you mean by that?
Oh, path CR means that basically, so in a lobectomy, whether it be like a left lower lobe, usually the surgeon takes out the whole lobe, and then the size of the tumor is measured. But sometimes in a rare case scenario, even though you thought that you were taking out tumor and are taking out tumor that is seen on a CT scan or a PET scan, sometimes that area no longer includes viable tumor cells, and that is called a pathological complete response.
All right, there's a few questions. We only have a few minutes left, so I'm going to go through these pretty quickly, Dr. Nagasaka. There's one that we do want to remind people that ceritinib is not something we recommend after crizotinib or entrectinib. Cabozantinib was one that showed some promise, but I don't know if that's a strong recommendation. We really want to try to get to a trial with one of the new ROS1 inhibitors or chemotherapy, also a very good option in that setting. But a question here, at what points do opportunities for biomarker retesting arise to find out if there's been a change in the cancer? And so when do you retest, Dr.
Yeah,
Negus?
so when there's progression or when something doesn't make sense, when all the areas are improving, but there's this one spot that's left, is that even the same cancer? So those are times when I consider a rebiopsy.
And this can be through liquid as well. And so I think that we're generally reserving it for at the time of progression or some growth, some sign that the cancer's evolved in some way. Here's a question. Do some patients respond better to pralsetinib versus selpercatinib? And we don't really have that information. Those trials haven't been done. I find that the response rates to both are very high. I think the drugs are much more similar than different. Let me pose this question to you, Dr. Nagasaka. Thoughts on which first-line TKI to use for stage 4 if there are no brain metastases? And so what would your choice be for ALK and for ROS1 with no brain metastases?
So I think those are excellent questions. And again, it will depend on the patient's preference, the side effect profile, comorbidities, all of that. All things equal, I tend to prefer the use of loratinib in ALK patients and the use of entrectinib in ROS1 patients, assuming that there are no frontline clinical trials available. And the reason for that is because of the very high CNS penetration of these drugs. And even if a patient does not present to you with brain metastasis, I think preventing them is key.
Yeah, I think that neuroprotection is very important. And we'll see if we can get better at maybe further personalizing some of those drugs, like maybe by fusion variant or other co-mutations. But I think that my practice, lorlatinib, is something that I occasionally use. But I probably use brigatinib a bit more in the frontline setting, or alectinib. And I think there's a lot of room for personalization depending on the specific clinical situation here. There's a quick question on a topic we didn't cover, BRAF. Dr. Nagasaka, does BRAF in non-smokers still respond to immunotherapy?
I think BRAF and KRAS are kind of similar in a sense that I have seen response to immunotherapy, even though they had a driver mutation like BRAF or KRAS. I think it is a different tumor biology. I'm not entirely sure about the data on BRAF with smokers versus non-smokers.
Yeah, it's not entirely clear. I think that when I use immunotherapy there, so for BRAF, my practice is targeted therapy first, but then if there's progression or not good tolerance, I usually use chemoimmunotherapy, and we'll see responses, but I also
Right.
that's the
So I
key.
agree with that. I think for BRAF, there's data to use immunotherapy and targeted therapy concurrently, right?
Um, Chemotherapy or targeted therapy?
Targeted therapy for melanoma.
Yeah, for melanoma it is, yes.
Yes.
And there's maybe in the last minute, when one is diagnosed with RET fusion and has a lobectomy and chemo, what's the possibility of recurrence? And right now, we would still generally cite the regular numbers for all non-small cell lung cancer. But a helpful thing from these adjuvant trials is not only showing the benefit of a RET inhibitor, but in the placebo arm to really see what our standard of care is offering. And we see in the ADORA study, in that control arm, with surgery and chemotherapy, we don't actually cure very many people with stage 2 or 3 EGFR mutant lung cancer. The recurrence rates are quite high. We'll see if that holds true for RET. So I think the jury's still out, but we'll have that information in the relatively near future. That takes us to our break. And so I want to thank Dr. Nagasaka for a wonderful talk and for fielding most of these questions. We come back at 2 o'clock Eastern time for the patient and research advocacy presentations from Ivy Elkins. But right now we take a break, and so look forward to seeing you at the top of the hour.